Season 2. Today's talk slide seminar is about clinicopathological case discussion 2 by Dr. Debayoti Chaterjee, Assistant Professor, Histopathology, PGI Chandigarh, and Dr. Ritin Mohindra, Assistant Professor, Internal Medicine, PGI Chandigarh. We have 6 participants. I request the students to introduce themselves.
Myself, Dr. Neha Desai. I'm second year pathology resident from Krishna Vishwavidyapit, Karad.
I'm Dr. Bishakha Deb, second year postgraduate student in Grand Government Medical College, Mumbai.
I'm Dr. Harita, second year pathology student, PG student from PES Medical College, Kuppam, Andhra Pradesh.
I'm Dr. Vamsi Krishna, third year PG from AIMS Bhubaneswar.
I'm Dr. Kavya, second year, first year postgraduate from Regional Cancer Center, Thiruvananthapuram.
I'm Dr. Vamsi, second year resident, AIMS Bhopal.
Moderators for today's session, Dr. Loma Parik, Consultant Histopathologist, Zydus Hospitals, Ahmedabad. Myself, Dr. KB Vatsala, Assistant Professor, KMC Mangalore. Webinar hosts, Dr. Anita Borges ma'am and Dr. Sumit Gujral sir. These are certain reminders. If there is any connection interruption or low sound or no sound, video freezing, video lag, please leave the meeting and rejoin with the same link. If problem persists, please check the internet connection. Please answer the poll question by typing in the chat box, and please do not send requests for annotation to the presenters. These are certain disclaimers and some more. Our upcoming talks, thesis writing on 22nd August by Dr. Swapnil Rane, TMH Mumbai. And on 24th, we have skin lesions, a case-based approach by Dr. Rajalakshmi T, St. John's Medical College, Bangalore. So without much ado, I request the speakers to take over the session.
Good evening, everyone. So, myself and Dr. Debayoti and my colleague in internal medicine, Dr. Ritin Mohindra, will be presenting this CPC today. So, Dr. Ritin will be presenting the clinical protocol and discuss the clinical aspect of this case. Then I will be showing you the autopsy protocol. Over, Dr. Ritin.
So I'll start the clinical protocol. I believe the protocol has already been shared in the group. So I'll not read out the entire part. I'll just be very brief. So am I audible?
Yes, sir.
Yes, sir.
Yeah. So we had a patient, Mrs. N, who was a 22-year-old female. So she was admitted on 15th of August in 2022, and her date of demise was 26th of August. So total hospital stay was around 10 to 11 days. So the presenting complaints were fever for 1.5 months, which was intermittent, documented up to 102 degrees, associated with evening rise of temperature. She had headache for 1 month, which was holocranial, moderate in intensity, and altered mental status for 20 days in the form of decreased responsiveness, irrelevant talks, involuntary abnormal body movements, which were query seizures. So there was no history of vomiting. There was also history of dizziness, blurring of vision, history of loss of appetite, loss of weight, which was undocumented. No history of any focal deficit at presentation, loss of consciousness, no cough, chest pain, palpitations. In the past history, there was nothing significant. Obstetric history, she was married for the last 1.5 years and had a stillbirth at the age of 7 months in May 2022. That was 3 months prior to this presentation. In the treatment history, in July 2022, she had some documented history of taking complementary and alternative medications for some vesicular lesions over the scalp, and but the details were not completely available. She was admitted at Karnal for 1 week in the first week of August, where she received steroids as well as albendazole and anti-epileptics. On examination, she had a GCS of 11, and there were focal deficits. There was neck rigidity. There was there were focal deficits. There was left eye ptosis, left third cranial nerve palsy, and her other sensory motor system could not be examined. There were choroid tubercles which were present. Respiratory system were there were only bilateral pores creps which were present. In the investigations, she had neutrophilia initially, then it was lymphocytosis. Her platelet counts were in the normal range. At presentation, her liver enzymes were all normal, but after starting ATT, she had enzymes which were around 4 to 5 times the upper limit of normal. Then coming on to the other investigations, her CMV IgM was cytomegalovirus IgM was non-reactive. Antibodies for toxoplasma by Lysa were negative. Antibody for cysticercosis was negative. ANA was negative, and HCV hepatitis B were negative. Immunoglobulin profile was normal. CD4 substrate was normal. CSF, which was done outside, there were only two cells with sugars of 18 and proteins of 117. We did not have the corresponding blood sugars. Then the CSF was repeated at our institute, where the cells were 311 and neutrophils were predominant. 83% were neutrophils. And sugars, the proteins were raised, they were around 298, and CSF sugar was decreased, it was 30. Corresponding blood sugar was not available. So AFB was negative in the CSF. Gene expert was, MTB was detected. It was sensitive to rifampicin. Fungal cultures were negative. India and Cryptola negative. Toxoplasma PCR was negative in the CSF. In the radiology, there was mild communicating hydrocephalus, multiple nodular ring enhancing lesions, bilateral basal ganglia, infarcts were there, and predominant basal and with diffuse leptomeningeal enhancement. And there was areas of parenchymal enhancement, and left uncal herniation was also seen in the MRI. So based on this, uh, anyone would like to go ahead and give me some differential diagnosis?
So based on the presentation, okay.
Continue, Vishaka.
So based on the presentation of the patient and that she developed meningitis and a workup where her CRP was raised, then her CSF also showed this raised count. There was pleocytosis and which was neutrophilic at PGIMR, and the gene export was positive. It is indicating disseminated tuberculosis.
Yeah, so the first diagnosis was tubercular meningitis for us, but what was atypical was usually in tubercular meningitis, especially if the illness is there for 1.5 months, we find a lymphocytic predominance. So here it was 83% were like neutrophils, and hypoglycorrhea was there. So usually that is not associated with tuberculosis. It is more common in bacterial and other carcinomatous meningitis. So yes, one differential diagnosis is tubercular meningitis. Any other reason why clinically you are saying it is tubercular meningitis?
So choroid tubercles were positive in fundus, which is more likely a finding of miliary tuberculosis.
Yeah. So choroid tubercles also point towards tubercular meningitis. So what can be the other differential diagnosis?
Bacterial meningitis.
Okay. So bacterial meningitis, do you have such a long history, or do you see ring enhancing lesions?
It would be more acute. However, the CSF count due to neutrophilia, it indicates bacterial, but
Okay.
the presentation would be more acute. Here it was a more, it was spread over 4 weeks or so.
Yeah. Okay. So now we move on to the next student. So Vamsi Krishna from Bhubaneswar.
Yes, sir.
Any other differential diagnosis that you would like to?
No, sir. Only bacterial meningitis is my DT. Bacterial meningitis and tuberculous meningitis.
Okay.
Even the patient is having fever since 1.5 months, which is with evening rise of temperature and headache. This will point towards the increased CSF pressure causing hydrocephalus.
Okay. So then we come to the course and management. So this 22-year-old female presented with these complaints based on the MRI findings, keeping the diagnosis of neurocysticercosis. Remember, there were ring enhancing lesions, and at the outside hospital, the CSF was more or less normal. There were no cells, so she was managed with albendazole and steroids, but there was no improvement. When she was referred to PGI, so she had neck rigidity, anisocoria, left eye ptosis. She was started on ATT. She developed ATT induced hepatitis, so the ATT was modified, but the patient's sensorium worsened, and eventually she succumbed to her illness. So clinically, the treating unit. So I was not the treating physician. So whatever information I have from the file, so that diagnosis was tubercular meningitis with meningovasculitis with multiple infarcts and tuberculomas, with left oculomotor palsy, raised intracranial pressure, ATT-induced hepatitis, and the cause of death was raised intracranial pressure. Right. So the important thing to know in this whole presentation as a clinician is what can be the other differential diagnosis. So can anyone tell me what can be the other differential diagnosis? So bacterial meningitis we said, tubercular meningitis we said.
Parasitic, this thing, neurocystic sarcosis as it was considered due to the MRI findings.
Yeah. So I'll try and share my screen. So is my screen visible?
No, sir.
No, sir.
So,
Can you all see the screen now?
Not yet.
No, sir.
Can you see the screen?
No, Ritin, we are unable to see the screen.
I'll just stop this.
Are you, you see the share
Yes, ma'am.
icon down there? Debayoti, do you have a part of his presentation? Can you share that screen?
No, ma'am, I don't have his presentation, but I think
It's come.
it's coming.
Hmm. Yeah, Ritin, we can see your screen.
Dr. Ritin, you're muted.
Screen has got stuck now. What's happened?
Yeah, now can you hear me?
Yes, very well, Ritin.
Yes.
Yeah. So in the clinical database, we have in the history, we have a young female who presented with fever, headache, vomiting, classic signs of meningitis, altered sensorium, and seizures. In the clinical features, the GCS was 11. There was anisocoria, neck rigidity was present, third cranial nerve palsy. In the investigation, she had leukocytosis, hyponatremia, and neutrophilic pleocytosis in the CSF with hypoglycorrhea, and gene expert was positive. There were choroid tubercular, CT showed miliary pattern and ring enhancing lesions, and there was transaminitis after the starting of ATT. So so in chronic meningitis with neutrophilic pleocytosis and hypoglycorrhea, usually we have the differential diagnosis is usually infections, or it can be some kind of a neoplasm. So usually I told you chronic meningitis has lymphocytic pleocytosis, but neutrophilic can be seen in tuberculosis. Then with hypoglycorrhea, tuberculosis is a common, bacterial is most common. Mycobacterial infections are also quite common. Then rarely we can have neurocysticercosis, CNS toxoplasmosis, which can also cause this kind of a. So then the third database point we have is the ring enhancing lesions. So ring enhancing lesions can be seen in infections, demyelinating disease, neoplasms, abscess. So all these would be our differential diagnosis. So I'll skip these. So these are some of the differential diagnoses of ring enhancing lesions. So if they are miliary or small, it's usually due to metastasis or tuberculomas. And if they are small, it could be metastasis again, tuberculomas, and medium also can be due to primary brain tumors, tuberculomas. And if they are large, it can be a cerebral abscess or tubercular abscess. Tuberculomas most commonly are seen in our tropical countries, and what is important is intracranial tuberculomas can occur with tubercular meningitis as well as meningovasculitis. So this is very important to differentiate it from neurocysticercosis. So on contrast administration, they appear as ring enhancing lesions. Neurocysticercosis is the most common parasitic disease, and you can see the different. So this is all clinical. So you can see the different stages in the radiology, right? What differentiates the two is neurocysticercosis. The lesions are usually smaller. Tuberculomas are a little larger on imaging. Associated meningitis is a very important differentiating point. It is absent in neurocysticercosis. It is present in tuberculomas. Then another important feature is tuberculomas. Usually focal neurological deficits are present like we had in our patient, and intracranial pressure is transiently raised in neurocysticercosis, but it is commonly raised in patients with tuberculosis. Constitutional symptoms like we had in our patient are also very common in tuberculosis. Then if we say the another differential diagnosis is toxoplasma. So it also there are also multiple ring enhancing lesions, and they may be hemorrhagic, and the ELISA is present in up to 95% of the patients. CNS lymphoma is another differential diagnosis. They are often solitary, and on CT they are hyper intense, and these are non-hemorrhagic. So the points of discussion would be the basic disease, what caused the acute deterioration in our patient, and the terminal event. Right. So basic disease, first possibility CNS tuberculosis. So what are the points in favor? Points in favor are fever, chronic meningitis, choroid tubercles, miliary pattern, ring enhancing lesions. The points which go against are neutrophilic pleocytosis, not very common, and the patient was on ATT, but still there was deterioration. Most likely the first possibility will be TBM. So this is a study from our own center. So adults in this though presenting in adults, the common CNS commonest was TBM. CSF levels in our ADA levels, they in our patient were 12, which also suggests tubercular meningitis. Neurocysticercosis, headache, seizures, ring-enhancing lesions, but the points which go against are constitutional symptoms, meningovasculitis, and absence of lesions in different phases, and a negative serology. So less likely to be neurocysticercosis. Neurotoxoplasmosis, again, the host was immunocompetent. The lesions in have intense cerebral edema. No meningovasculitis is there in neurotoxoplasmosis, and the toxoplasma PCR was negative in the CSF, so it is less likely. Again, cryptococcus, another differential diagnosis, same thing, immunocompetent host. The India Inc was negative, cryptococcal antigen was negative. CNS lymphoma, another differential diagnosis. Again, usually it happens in immunocompromised people. The lesion is usually single, and the uh, response to steroids is generally good. So it is also unlikely. The other possibilities can be nocardia, histoplasmosis, septic emboli, metastasis, or demyelinating disorders, which can all cause meningovasculitis or a ring enhancing lesion, but they were not in our case. So the basic disease was patient had fever, headache, altered mental status, multiple ring enhancing lesions. So the first diagnosis, because of the typical finding of CSF gene expert positivity we all discussed, is tuberculosis. What caused the acute deterioration was it could be possibly due to cerebral infarction due to vasculitis or hydrocephalus with raised intracranial pressure or drug-induced liver injury. Cerebral infarction affects up to two-thirds of the cases of TBM and is associated with poor outcome. Such extensive cerebral infarction, as we saw in the radiology, is very common in tuberculosis. The terminal events was it could be extensive infarction due to vasculitis or raised ICP causing uncal herniation. So when we put it all together, the diagnosis after the clinical thing and the radiology is tubercular meningitis with meningovasculitis with hydrocephalus, and the patient most likely had uncal herniation with mass effect, which caused raised intracranial pressure, and patient also developed ATT-induced hepatitis. Yes.
Ritin, can I ask you a question? Why
Yes.
did this patient have anisocoria?
Ma'am,
Where is
basically,
the lesion that causes anisocoria?
there was compression of the third cranial nerve. So the patient had multiple tuberculomas
I see. Okay. Was that within the brain or outside?
within within the brain, ma'am,
Okay.
in the radio.
Okay.
So the point I want to make is, even if it's chronic meningitis and you have a neutrophilic predominance in the CSF, hypoglycorrhea, tuberculosis should always be the first possibility, especially with such extensive meningovasculitis, meningitis, and ring enhancing lesions. So it should be tuberculosis could be your first possibility always. The patient, when he showed outside, she was started on treatment for NCC, neurocysticercosis. So maybe that is where we lost time. Maybe had it been picked up then, the outcome could have been different.
Okay. So, anyone has any question at this point of time? Start the protocol.
None in the chat box, sir. They have just given DDs.
So in the chat box, I can see you all have written some differential diagnosis. So I think I've already discussed all these points. So in this background, with a gene expert which is positive, there are choroid tubercles, there is meningitis, ring enhancing lesion, meningovasculitis. We cannot go away from tuberculosis as our first possibility.
Understood. Then we can move to the autopsy protocol in this case. So the purpose of giving this case was not to show you some exotic diagnosis or some surprise, but to see the spectrum of the disease and to show the extent of involvement and the clinicopathological correlation in such cases. So should I start sharing my presentation?
Yes, sir.
Yes, please do.
Yes, sir. Ma'am, is my screen visible?
It's visible, sir.
Yes.
Okay. So in this case, in this 22 years young female with the clinical diagnosis Dr. Ritin has already mentioned, and the 10 days of hospital stay, a complete autopsy was performed. So when we talk about complete autopsy, it means that it's whole body with brain. So that is the meaning of complete autopsy. So before I go to the brain, which is the main organ of interest in this case, I'll show you the other organs. Okay, so this is the organ complex. You can see this is the tracheobronchial tree and the bilateral lungs. Okay, so in this case, as you can see, the lungs together weight 664 grams. So is this weight normal for lungs in an adult patient?
Yes, sir.
Yes, sir, it is normal.
So between 650 to 750 gram is
600 to
normal
750.
adult. Okay. So this is the pleural aspect, right? So this is the left and this is the right lung. So as you can see the pleural aspect, this is very dull. Normal pleural is very shiny because it's a mesothelium covered organ and it should be very how can I start annotation? How can I start annotation now?
Do you see at the top of your screen, Debayoti, you'll see a little squiggle worm-like thing?
Yes, ma'am. Yes, ma'am.
Otherwise, are you the host? If you're the host, then you can just pull down that thing at the top. You know, you got an orange bar on top. Have you got an orange bar on top?
Yes, ma'am. Yes, ma'am.
Just pull it down and you'll see that there are some annotation. Can you see it? Could you pull that orange bar down or not?
Somehow my mouse is not working.
Oh.
So try double clicking, sir.
Yeah. Now it is coming.
Okay.
There are options.
That is a laser pointer, yes.
Yeah.
If you want a pen, you can use the pen too.
It's fine, ma'am. I can use this. That is fine. So you can see this pleural aspect. This is very dull. fiber-like things. So can someone guess what are these tags?
Fibrinous
Fibrinous
exudates.
tags.
Stacks.
Yeah, so these are basically fibrinous tags. So this indicates a fibrinous pleuritis in this case. So this is the close view of the same. You can see these fibrinous tags, this region, and the pleura is very dusky, and there is no the normal shiny pleura is not present in this case. Cuts. You can see these cuts are a little bit. It's slightly congested.
We've lost your voice.
Am I not audible, ma'am?
Debayoti, we've lost your voice.
Am I audible, ma'am?
Sir, it's very feeble.
Yeah, it's not. Yeah, not clear.
Is it okay, ma'am?
No, it's very, very low.
Now also it is low, ma'am.
Debayoti, are you home or in PGI?
Home, sir.
I think, can you log out and join again? Just log out and join again. In the meantime, I think we can request Ritin to, continue.
Am I audible now?
Voice is low, still low, sir.
Is it better?
Sir, same. Initially, you.
Hello.
Hello. Initially, my voice was fine.
Sir,
In between, your voice was.
It just came back to normal and went back again.
Yes. For a second, it came. It was audible. Yeah.
We saw lose connection.
Can you try again, sir? One more time. Can you speak? Sir?
Can't hear you, sir.
सर लैपटॉप में कोई इंक्रीज वॉल्यूम का की है जो आप
Otherwise, you connect your headphones, sir.
Yes.
Sir, you can log in using your phone and maybe audio can be connected from there.
Sorry?
You can also log in through your phone, sir.
Debayoti, what's the problem? Is there a problem with your laptop? Do you want to change the laptop if you can possibly do that?
I will call him. The Dr. Debayoti is joining now on the phone. He will do the PowerPoint from the computer, move the slides, but he will speak from the phone. He's joining in a minute.
Hello, am I audible?
Yes, now you are.
Okay, ma'am. Sorry for the inconvenience. I don't know what happened. Let me share again. Is my screen visible, ma'am?
Yes.
Yes.
Okay, now I think we can move like this. So lungs, you can see now. Can someone tell me what is the normal appearance of the cut section of a lung?
Should be spongy, sir.
Spongy, right? Because it has air inside. So it is called subcrepitant. Crepitant to subcrepitant. Right. So these lungs are more or less solid in appearance. Right? So what does it indicate? So it indicates either there is some consolidation on a pneumonic process, or it could be some diffuse alveolar damage. This one of those. These are the differential of such differential. Now, if we see have a close look at this lung, what can we see?
Gray white nodules.
Multiple subcentimetric nodules.
Yeah, so you can see these whitish nodules throughout the lung parenchyma.
Throughout the lung.
More prominent, you can see in the upper lobes. They are measured to 3 millimeter, very small, pinhead size. And many you can see they are kind of in a bronchiocentric location. There is a bronchiole, this kind of rounded structures in the center. Can you see this? Some opening at the center of this whitish nodules. These are bronchiocentric. And towards the lower lobe, they were more consolidated, they were more coalescing. So now coming to the histology of the lung, you can see these are normal alveolated air spaces, right? So these are alveolar spaces. In between, you can see some nodules, right? So these are some nodules here, which are more solid looking, and in the center of some of these things, you can see some this kind of empty spaces. So these are the basically bronchioles, and you can see this bronchiocentric distribution of these nodules, and you can see also away from these bronchioles. Now Someone can you please tell what are these blue-looking things in a lung section?
Cartilage.
Bronchial cartilages.
Cartilage. So this indicates that these are the bronchus, right?
Yes, sir.
Yes.
So you can see these are present along adjacent to the bronchus as well as away from this bronchus, and this is a pulmonary artery. So I'll come to the vascular system a little later. So a little closer view, you can see these are the epithelial cell
Epithelial
granulomas,
granulomas.
right? So these are converted histiocytes, and there are these giant cells and some lymphocytes. These small cells are basically lymphocytes surrounding this granuloma. Now, another focus, you can see this is a smooth muscle lining. So this is another bronchiole. It does not have a cartilage, so I'm calling this as bronchiole. And here the granulomas are eroding within this bronchiole, right? So endobronchial pattern of spread. You can see, and there is this sprinkling of lymphocytes. Another picture, you can see these multiple epithelial cell granulomas with these kind of giant cells, Langhans giant cells, and bronchial granulomas. And this is also coming near the pleura. So this is the pleural surface. A hypod to show the same. In the epithelial histiocytes, this from this well-formed granulomas, giant cells, this lymphoid cells, all these things. Now, what is happening here?
Necrosis.
Necrosis.
So you can see the central necrosis
Central.
in some of the granulomas. Right. Now, I was talking that this was eroding within the bronchioles. Now, you can see a bronchiole here. And can you see the smooth muscle lining? So this is a very irregular smooth muscle lining, this discontinuous smooth muscle lining. So this is some discontinued bronchiole. You can see this granuloma with necrosis, which is eroding within this bronchiole. So these are all basically endobronchial pattern of spread in this case. Now, can someone tell me what is this structure?
Blood vessels.
Right, a blood vessel. So you can see actually this is a continuation. This is a longitudinal cut of a blood vessel. This is a pulmonary artery, right? So branch of a pulmonary artery. Something is happening here, right? In the center. So what is this? Can someone guess what is happening, or we'll go to the higher power in the next slide? Okay. So this kind of a fusiform appearance in the center, right? So I thought this might look like a wristwatch. Now, if you see carefully now in a higher magnification, this is a pulmonary artery. This is the smooth muscle wall. Now there is complete disruption of the wall by this granulomatous reaction. So there is a secondary vasculitis. Correct? So
Yes.
the branches of the pulmonary arteries are kind of at least destroyed. If you see, this is EVG stain. So this is the internastic lamina. So after coming here, there is complete disruption of the internastic lamina. So this is a vasculitis. So what kind of vasculitis is this? You are seeing granuloma, vasculitis. So what else can you think of?
Necrotizing vasculitis.
Correct. So can you think of any differential diagnosis?
Any autoimmune condition like no? Any autoimmune condition?
Which autoimmune condition you can think of?
Wegener's
Wegener
granulomatosis.
granulomatosis.
What is the current name of vaginal granulomatosis produced with
Granulomatosis.
Cysts with polyangiitis.
polyangiitis.
Okay, so granulomatosis polyangiitis, correct? So sometimes this pathology of TB and GPA can look very similar, especially on a small biopsy if there is too much of vascular involvement. So remember that these are always differential diagnoses, sometimes clinically as well as histologically. So you have to remain careful and always you have to do special stains. And so this is a viewer strongly positive. So this is one representative section I am just showing. So remember that in TB also you can have vascular pattern of spread. So this miliary spread, basically there is vascular involvement. Okay, now this is another picture where we're seeing this bronchiole and there's an artery accompanying it. So which artery is this? Which artery in lung will accompany the bronchioles?
Pulmonary artery.
Pulmonary artery.
Yeah. So not bronchial artery. So this is a branch of pulmonary artery. And what can you see here?
Thrombus.
Right.
Right. So there is a fibrin thrombus here.
Fibrin thrombus.
So in lung, in addition to this tuberculosis and vasculitis, you have evidence of pulmonary thromboembolism. So there might be where we could see the presence of this pulmonary thromboembolism. So this could be a terminal event in this patient. Now coming to this organ complex, we can see this slice of liver. This is C loop of duodenum. This is the pancreas and spleen. Liver weight 1200 gram. There was no nodularity on the surface or on the cut section. The spleen was also slightly enlarged, but it was firm. Now coming to the low power inspection of liver, you can see these are the portal tracts, correct? So the periportal hepatocytes are nicely preserved, whereas as you move away from these portal tracts towards the central veins, you can see the hepatocytes are very small, they are getting disintegrated and they are kind of atrophic, right? So another high power, you can see this in the periportal region, the hepatocytes are better preserved, and in the centrizonal area there is, like here, there is complete loss of hepatocytes, indicating that there is hepatocytic necrosis. So this is a centrizonal pattern of hepatocytic necrosis. So what are the different causes where you can get this kind of centrizonal hepatic necrosis?
Drug-induced.
Okay. Drug-induced is one possibility. What are the other possibilities?
Ischemia of T.
Very right. So one is ischemic hepatitis, one is drug-induced liver injury, DILI, and some cases of acute viral hepatitis like viral hepatitis A can also sometimes show you this centrizonal pattern of injury. So if we want to see the duration of this injury, now this is reticulin stain, right? So can someone tell what is the interpretation of reticulin stain in this video? What is happening to reticulin stain?
So there is reticulin collapse.
Right. So in the centrizonal area where we saw there's necrosis, there is reticulin collapse and condensation. Right? The reticulin fibers should be one cell apart, right? In this area, you can see this single cell pattern of hepatocytes which is separated by these reticulin fibers. But here you can see this reticulin are all coming close together. So what does it indicate?
Can I interrupt you? Can you make your pointer into a laser pointer, please?
Sure, ma'am. I'll do that. Laser, right. Is it visible, ma'am? Ma'am, is it visible?
Yes,
Laser,
sir.
laser
Sir,
pointer. Okay.
please switch off
Yes.
your video, sir.
Sorry.
Your video is off. If
Oh,
you
my
could
video
please.
is off.
Yeah, yes, sir.
Wait, wait. Is it visible? No. Is it visible now?
No, sir.
No, sir. Yes, yes, visible, sir.
Okay, right.
Now you can share your presentation.
Yes, ma'am. Fine. So can continue from here.
You'll have to make your pointer again into laser pointer.
Oh yes, every time I leave, I have to use it.
Yeah, that's right.
So nice. So there is now
Yeah, that's
this
fine. That's good.
reticulin collapse. So what does it indicate? Vamsi, can you tell what this reticulin collapse and condensation will indicate?
Sir, because of the necrosis, there is hepatocyte loss. So the reticulin stain which is surrounding these hepatocytes will be seen condensed together.
Right. So that is correct, but it also indicates that this hepatocyte necrosis is not just terminal, because the reticulin will take 24 to 48 hours to this condense. So sometimes pre-terminal ischemic hepatitis can also show you this kind of centrizonal hepatic necrosis, but this will indicate that there is this hepatocytic necrosis or injuries of some time. Okay, so this is mesenchymal trichrome stain. You can see there is no significant increase in this portal fibrosis, and this where you saw this reticulin condensation, these areas are also devoid of this fibrosis. So this indicates that these are only because of necrosis, but there is no bridging fibrosis or something like that. In addition, you could see this some granulomas. Some of these were portal based, as well as some were in the hepatic lobules. This is, can anyone guess which organ? You know, I believe you all know. These are islets. These are acini. So
Pancreas.
pancreas. So pancreas was normal. What could be this organ? What is this? This band-like tail.
Spleen.
Spleens.
So this is basically a trabecule, correct? So this is spleen. As you can see, there is mild expansion of this red pulp, and here also you could see some granuloma. So the TB was disseminated, not only limited to lung, also involving liver, spleen, and other organs. Kidneys weighed 290 grams. They were slightly, they're normal in size, slightly discolored, and it actually showed this kind of some medullary congestion. The glomeruli were fine, and in kidney also you can see this necrotizing granulomas, right? Granuloma with this central necrosis, and AV was positive in kidney also. This is heart heart weighed 190 grams. The valves and chambers were all normal. This is the section from myocardium, which also did not reveal any significant alteration. There is no granuloma in the pericardium. The esophagus, stomach, small large intestine showed some mucosal congestion. There was no nodularity, and microscopically also there was no granuloma or any problem. So these are the uterus, bilateral ovaries. They are microscopically unremarkable. Skeletal muscles, adrenal, skin, and they were normal. Bone marrow was normocellular for age and showed trilineage hematopoiesis. Now, I will start with my discussion in brain. So you can see this is the superior view of brain. Brain weighed 1183 grams. Can someone tell me what are these whitish granular things on the upper surface of the brain?
Exudates.
Exudates, inflammatory exudates.
So this is the common thing that always thinks they will think this is exudate, but no, this is very normal for human brain. These are called arachnoid granulations. Okay, so the arachnoid villi, when they drain into the superior sagittal sinus, here, superior longitudinal sinus, they form this granulation along the both side of the midline. So here we can see there is slight, this gyri are slightly swollen and the sulci are very narrow. Again, you can see from the lateral view of this brain, the gyri are slightly swollen with narrowing of this sulci here, right? So what does it indicate?
Edema.
Edema of the brain.
So yes, so it indicates that there is some edema. Now this is the base of the brain. So what is this structure? Can someone tell me what is this structure?
Brain stems.
The brain stem is a big structure actually. So this is the cervical cord and the medulla.
Medulla.
Okay. Actually, what is happening here? You can't see the structures in the base of the brain very clearly. Correct. Because there is some hazy thing which is covering it. So this is basically an exudate. So this is a classical example of a basal exudate. Okay, you can see these are the olfactory tract. This is the optic tract and optic chiasma, but you can't see it clearly. Inside you should have mammillary bodies. So the structures in the base of the brain or interpeduncular fossa are completely covered with this basal exudate, right? And if you can try to see, these are two arteries here which are coming and joining and forming another artery. So can someone guess what are these two arteries?
Vertebral arteries.
So right, very nice. So two vertebral arteries joining to form this basilar artery.
Basal artery.
Right? And basically this is the basilar artery, and entire circle of Willis is here, which is embedded within this exudate. Now if you notice, these two parts on both sides of this interpeduncular fossa are quite swollen. Normally they are not this kind of swollen. So these are basically uncus. So uncus is quite swollen and it's herniated. So indicates that there is an increased intracranial pressure. Now in this picture you can see that the brain stem here I have removed after cutting, right? So this is the circle of Willis. Okay. So after internal carotid artery, it has divided here into anterior cerebral artery and middle cerebral artery, right? So these are the branches of these are the fragments of, sorry, these are the elements of your circle of Willis, which is actually embedded within this exudate. I'll show you why I am talking about this vascular structures. Now we have cut the brain in coronal slices. Now we have labeled it as left and right as we have taken the photos. Now this is a section you can see. This is white matter and this is gray matter, right? So if you see it here, the normal gray matter is of this kind of color, slightly grayish. But if you see these cortical ribbons here in the superior and middle frontal gyrus, they are quite discolored, right? They are more of grayish or blackish kind of discoloration you are seeing. So dusky gray discoloration. So can someone tell me what this color indicate?
Infarct.
Not truly infarct, but yes, hypoxic changes. So these are hypoxic changes. You can see this hypoxic change here. Almost entire frontal cortex is showing this kind of discoloration, and it is more prominent in the depth of the sulci, right? And also in the cingulate gyrus, right? So these are the areas which are supplied by anterior cerebral artery, and these are the areas which are supplied by middle cerebral artery, right? And this is the watershed area. Now, in addition to that, if you see carefully, there are some small nodules here. Can you appreciate this one here, one small nodule here, a few nodules here? So measuring 3 to 4 millimeter. So what could be these small nodules? Can someone identify them?
Tuberculomas.
Tuberculomas.
So right, so these are tuberculomas. So I'll show you the different anatomical structures and how these tuberculomas are located. Now this is a section which is taken slightly behind. So this is at the level of thalamus. So if you try to see the normal structures on this is right and this is left again. Now what are these? These two
Third ventricle, lateral ventricle.
This is the lateral ventricle, right? Lateral ventricle, this is the third ventricle. Okay, this is thalamus, right? This is internal capsule, right? This is globus pallidus, interna, externa. This is putamen, this is gray matter, right? Then comes your external capsule, then claustrum, then extreme capsule. This is insular cortex. Right. So this anatomy, if you have understood on this side, now you compare this right with this left side. What is happening on the left side? Can someone describe what is happening here? So there is complete breakdown of this brain matter here, right? You can't identify where is the thalamus, where is the internal capsule. This was the internal capsule which was coming here, but now it is all necrosed and destroyed, right? So this is infarct. This is an acute infarct, correct? Now, can someone tell me this infarct is in which vascular territory?
Middle cerebral.
Right, very right. So this is MCA territory, middle cerebral artery territory. Now, what are the middle cerebral arteries there? So this is your Sylvian fissure, right? So the middle cerebral artery, the M2, M3 branches will traverse through this Sylvian fissure. Can you see this? Some blood vessels here, some branches. Can you identify them on this side?
Yes.
So they are more patent here, correct?
Yes.
But if you see them here, they are kind of covered with some hazy thing. So they are here covered with exudate. So this vessel, the branches of this middle cerebral artery on this side are showing this kind of, they are covered with exudate, and we'll show you how they are being affected in this disease process. Now, going further back, on right side also, this kind of infarct you can see involving the thalamus, internal capsule, and this you can see this discolored cortex here. But see, this cortex integrity is fine. They are neither thinned out, not destroyed, they are not breaking down. And in addition, you have these small nodules here, right? This is in the white matter. Now, this is a microscopic section. This is from the basal region. So this is from the basifrontal region. You can see this is the thick exudate here. So this is the exudate here, and you can see these vessels are entrapped within this exudate, right? So what can you see in this exudate? These are all composed of this inflammatory infiltrate, numerous macrophages, lymphocytes, and neutrophils. Remember, in this case, there was neutrophilic pleocytosis. You remember in the CSF picture, Dr. Ritin was discussing that there was neutrophilic pleocytosis rather than lymphocytic. No, so here also you can see a lot of neutrophils. And what is happening to the underlying brain parenchyma here? There's a lot of vascular proliferation.
Increased vascularity.
Right? And in this exudate, there's numerous acid-fast bacilli. And now these are the branches of the middle cerebral artery. Right? So what is happening to these branches? Can someone describe? So these are all embedded within this exudate. What is happening here?
Increasing the thickness of vessel wall.
Proliferation.
So there is some intimal proliferation. And on this EVG stain, you can see this internal elastic lamina is very nicely preserved. So there is no disruption of the internal elastic lamina here, but there is some intimal proliferation. Okay. But when we see the smaller branches, like these are the M3 branches and the perforating arteries, branches of the MCA, what can you see here?
Occlusion of the lumen.
So there is fibrinoid occlusion, and what is happening to the wall?
Fibrinoid necrosis.
Yes, there is transmural fibrinoid necrosis, correct? This necrotic debris and the necrosis, the inflammation is all through and through going into this artery and destroying it. And the same thing you can see here in EVG, right? EVG stain, you can see the internal elastic lamina on one part, and after that, this is completely disrupted. So this is again some meningovasculitis. And this is internal elastic this is the internal capsule. You can see this is Luxel fast loop PF10. So the so this internal capsule is a very thick band of, this is white matter tract, correct? So what is happening here? You can internal capsule is kind of broken down at places, and there is disruption of this myelinated tracts. So what do you understand by this? Can anyone tell? So this is internal capsule, which is a myelinated tract, white matter tract. Now here this myelin is disappeared. So this is a secondary demyelination, which is basically because of infarction. Right. So remember that one of the common cause of demyelination is
Infarction.
vascular damage, yes, infarction. And if we have a close look here, we can see this, the tracks are completely disrupted. There are vascular proliferation and this macrophage infiltration in the background. And on a closer look, in the areas of infarct, we can see the smaller vessels also, which are showing this fibrin thrombi, and there is this neutrophils, which is kind of transgressing through this vessel. So MSB showing some fibrin here within these vessels, and this is another area where we showed the spot, the cortex immediately beneath those exudate. You can see a lot of neutrophils along with this kind of vascular proliferation. So this indicates that this is very acute infarction, right? So if you see these neutrophils, so what would be the approximate age of this infarct here? Note here there is not much macrophages in these areas.
2 to 5 days.
2 to 3 days, because mostly after 4 days, some macrophage infiltrate will start coming, right? And they'll predominate after 7 days. Now, in this picture, which is taken from one of the basal ganglia region, we can see what are these cells?
Histiocytes.
Okay, so these are rich in histiocytes along with some vascular proliferation and some gliosis. So what does it indicate? What would be the age of this infarct?
2 to 3 weeks.
Not so high, because by 14 days macrophages will mostly disappear. So definitely more than 7 days I would guess, because this is something between 7 to 14 days, because the neutrophils have completely disappeared in this region. So this indicates that there are multiple incidents of infarction in this brain, right? So there is multiple and recurrent infarcts. Now this is section from one of these nodules, you can see, and this is basically a tuberculoma. You can see this central necrosis, and peripherally you can see these histiocytes and some lymphocytes, and then higher magnification we can see histiocytes, some giant cells here. So these were the tuberculoma. Now these are the sections from the cortex. As we told you that there is this kind of discoloration of the cortex here, right? So these are the sections from cortex. So you see here, normally the cortex should be very pink looking, but you can see here these are very pale. You see this whitish appearance of this cortex. This is certainly not pink. It should be as pink as this, but these areas are whitish. So let's see what is happening on a closer view. So you can see again these multiple patches of these whitish areas. These are not seen only in the cortex, but also in the subcortical white matter, right? So this is the Luxalfar blue PF10. Again, you can see this white matter, which should be as blue as this. This is the normal white matter, this myelin, but here they are very pale looking. So again, there is some secondary demyelination, but remember, this is not involving only the white matter, which should be there in primary demyelination. Primary demyelination, like multiple sclerosis or like that, those are disease of purely white matter. But here, the disease involving both the white matter as well as the gray matter, which indicates that these are some secondary demyelination. Okay, and so these are again because of diffuse hypoxia. Now, choroid plexus, we can see what are these?
Dystrophic calcification.
Right, dystrophic calcification, and the choroid plexus also showed this kind of granulomas and histiocytic collection. This is the pituitary. You can also see there is hypophysitis with infiltration by these lymphocytes and macrophages. It's not uncommon to get hypophysitis. So this is CD68 here, and this is CD3 showing this hypophysitis. Now coming to the brain stem, which is very interesting in this case, this is the midbrain pons. So these areas also showed extensive involvement by this infarct. They were kind of breaking down, discolored, and some areas showing this kind of hemorrhagic. And this was involving predominantly the dorsal part of the pons, right? And also extending into the fourth ventricle. Fourth ventricle is there almost completely occluded, right? And the cerebellum are appearing fine. Now this is the section from the pons. Can you identify these decussating tracts?
Yes.
So there is an artery in front of pons, which is again embedded within this exudate. What artery this is? So this is basilar artery, which traverses to the ventral part of the pons. So I will show you this basilar artery here. So here you can see this basilar artery. We are again showing this intact internectic lamina, but there is a significant amount of intimal proliferation and periarteritis. So this exudate is showing this on the adventitial aspect, and also some extent up to the media, but not breaking this internectic lamina. And those exudates are also extending along this cranial nerve. So this is a section from the third cranial nerve in the midbrain. You can see this cranial nerve is completely entrapped and encased by this inflammation, right? So which can explain the cranial nerve palsy in this patient. Now these are the pontine tracts. Here you can see lot of pale areas. So these are again infarcts. So this is your GFAP stain. You can see these the glial fibers here in the white matter tracts, but here you can see there is these areas are looking very pale. So the glial fibers here are disrupted, right? Again, this is looks sulfur blue stain. You can see this white matter tracts, and these are disrupted here by these pale areas. So there's loss of myelin. So a close look, you can see this. So in between the tracts, what should be present in pons? Can someone guess? These areas, some neurons are here in between the pontine tracts. So these are basically cranial nerve nuclei, pontine nuclei, right? So pons has the decussating tracts, and in between you have this pontine nuclei. So both this gray matter as well as white matter are showing these pale areas, indicating there is infarction. So you can see these pontine nuclei. So some of the neurons are well preserved here, whereas these ones are almost completely very pycnotic. They are small, indicating severe hypoxic changes the adjacent to the areas of infarcts. And also because of this vasculitis here, there is some hemorrhage within the pons. And you can see here again this pale area is complete loss of this pontine nuclei. Same here. So here also you can see this pale area. The white matter should be very bright pink. They're almost disrupted this foamy appearance. And here you can see some pink glassy structures, round structures. Can you identify them? Can you recognize these glassy pink structures? It's okay if you are not able to identify. Show you. This is neurofilament protein.
Yes.
So can you identify this neurofilament protein stain? These round structures. Do you see them?
Yes.
So what are these round structures? Can someone guess? So these are basically axonal retraction bulb. So when there is axonal damage, So the axons will retract and they will form this kind of bulbs. Okay. So these are features of axonal damage, diffuse axonal damage, which can be a primary pathology or a secondary pathology, like here, like in case of infarcts. So as Dr. Ritin also said that cerebrovascular complications are very common in tuberculous meningitis, but this kind of extensive cerebrovascular complications with bilateral infarcts and involvement of brainstem is quite unusual. So that was the case, and here also you can see this was a paper from our institute where they showed very common involvement of the vessels, but mostly in smaller branches. But as you saw here, the main branches of like MCA, basilar artery, they were also showing intimal proliferation in this, and that was this was an autopsy-based study we saw previously. So this is the final autopsy diagnosis in this case, tuberculous meningitis with multiple tuberculomas, poraplexitis, and multiple infarcts in the bilateral MC and basilar artery territory. And in addition, there was global hypoxic changes in the brain, and there was miliary tuberculosis involving the lungs, liver, spleen, and kidney. There was multi-acinar confluent hepatic necrosis, which is consistent with ATT-induced hepatitis and pulmonary thromboembolism. So that was the presentation here. So any questions from the students if they have any query? Am I audible, ma'am?
Yes, absolutely. I don't see any questions in the chat box, but please, I think it was such a fantastic, sort of, I would say, a tour de force of neuropathology, which I think neurotuberculosis is actually an epitome of neuropathology. Everything that you expect to see in neuropathology, including what we call space-occupying lesions, are shown in tuberculosis. It is really it's an example, an extreme example of all of the different pathologies. In fact, I think all of general pathology you can see in one disease, and that is neurotuberculosis. I'm sure you'll agree with me, Debayoti, that this is really a wonderful. It's sad for the patient who has to suffer this, but you can see vasculitis, you can see thrombosis, you can see exudates, you can see infarcts, you can see inflammation, different kinds of inflammation. You see degeneration because of what happens to the tracts and the fact that demyelination is occurring, etc. And something, of course, you don't see neoplasia, but we use the term tuberculoma because it looks like a space-occupying lesion. So everything that you might want to see in general pathology, you see in neurotuberculosis. Do you agree with me, Debayoti?
Yes, ma'am. Yes, ma'am. I completely agree. Actually, I had a MD thesis on tuberculous meningitis, so that brought my interest towards neuropathology. And when we came across I read those papers by Dr. Dastur.
Absolutely, Dastur and
So
Lalita.
those are the pioneers of Indian neuropathology, which came
Anybody
from those.
who wants to really, and it was they wrote this paper called I think it was in Progress in Neuropathology Volume 2, if I remember. My God, it's a long time ago, but it has made such an impression on my brain. He had a colleague called Dr. V.S. Lalita. So Dastur and Lalita, if anybody wants to read that, it is absolutely a seminal work. And I'm so happy, Debayoti, that you showed all of those lesions in this one case. of this very unfortunate young lady who was missed. The diagnosis was missed for a long period of time, and I think she may have been saved, perhaps with some morbidity, but she succumbed to her illness. No, I think that this was a really great case. Are there any questions that anybody would like to ask? And the answer to my question as far as why was there anisocoria was there. It was there in the beautiful sections that were taken from the third nerve. And yes, I think that it was really something to behold. You know, I don't know how to say this to young people, but I am, and all of us who do histopathology are privileged. We are really privileged to see and understand what other people can only hope to imagine. Okay, you see everything, both grossly and microscopically. And if that does not excite young people, I don't know what else will. You see how cells talk to one another. You see how they interact with one another. You see how cells heal. You see how tissues heal, and you see how they succumb, how they die. I mean, what else can be so exciting that you can see everything that a surgeon has to imagine, a physician has to imagine, everybody has to imagine, but we can actually see. And today I really thank you, Debayoti, for showing all these students in such a sort of beautiful way, with all the stains and everything else, what is happening to tissues and in fact the brain as an organ, right from the cells and to the larger parts of this organ, what damage tuberculosis has done. Really, truly, it is an epitome of neuropathology. Thank you. Thank you very much indeed for choosing this.
I want to add one thing, ma'am. What was very interesting from a neuropathological aspect of this case, we know that cranial nerve palsy do occur in tuberculous meningitis because of the exudates entrapping the cranial nerves. But here, in addition to that, there was significant damage to the brainstem nuclei by this infarction. When we took section from the periventricular region in the midbrain, where the third nerve nuclei is there actually, third nerve nuclei, fifth nerve nuclei, they were all severely damaged. So I think this case teaches us where all the pathology of tuberculosis, in how many ways it can damage the brain.
Yeah, that is something that I learned from reading. Well, I was only a medical student. I was a postgraduate in pathology when they wrote that. I think it was in 1973. I appeared for my MD in 1974. But that new Progress in Neuropathology, Volume 2, it is like imprinted on my brain. It was such a wonderful topic. Of course, in those days, there were no color pictures. It was only black and white. But they wrote that wonderful paper, and now you have brought all of that black and white to color. Thank you very much, Debayoti.
Thank you so much, ma'am, for this opportunity.
No, thank you. Because